respected chairpersons, senior members of IPS, teachers and my dear colleagues. At the outset, let me thank the organizers for giving the opportunity to present a topic at SIPSCON 2013. Delirium is an acute and fluctuating cognitive impairment which is characterized by decreased ability to attend and impaired consciousness. And Lipstein and Lefkow in 1992 described three phenomenologic subtypes of delirium: hyperactive delirium, hypoactive delirium, and mixed type, in which hypoactive delirium is characterized by four or more of the following features, which includes unawareness, decreased alertness, sparse or slow speech, lethargy, decreased motor activity, staring, apathy, and lack of interest. The prevalence of overall delirium in community is around 1 to 2%, and as the age advances, the prevalence increases. And out of this, 40 to 86% is of hypoactive type. And it is unfortunate that around 66 to 84% of hypoactive delirium remains unrecognized. The implications of under-recognition of hypoactive delirium is that it leads to prolonged hospital stay, greater dependency of care on discharge, a future risk for functional and cognitive decline, poor rehabilitation potential, increased morbidity. The 6 months mortality is being increased by 3 to 5 times, and it also results in hospital complications and frequent rehospitalization. And various predisposing and precipitating factors are being described for development of hypoactive delirium. The host factors include age greater than 65 years of age, a male sex, previous history of hypoactive delirium, an ApoE4 polymorphism, a presence of minor or major cognitive disorder, presence of depression, alcoholism, smoking, and a presence of sensory impairment like vision or hearing impairment. As in the graph, you see as the age advances, the chance of development of delirium increases. And the factors of critical illness for hypoactive delirium include acidosis, anemia, thrombocytopenia, fever, infection, hypertension or hypotension, various malignancies, respiratory diseases, and evidence of inflammation, dehydration, hyponatremia or hypernatremia, structural brain lesion, hypoxia, hypoglycemia, hepatic or renal impairment, hypercalcemia, and high severity of illness. And as the Apache 2 score increases, the chance of developing delirium also increase. And the iatrogenic factors which are described include various surgical procedures, a use of physical restraint or catheterization, immobilization, injudicious use of psychoactive drugs and other medications, and sleep disturbances. As the dose of lorazepam increases, the prevalence of delirium also increases. And other risk factors explain that a long duration of surgery, intra-abdominal surgeries, pre-operative therapy with diuretics, a prolonged aortic clamping time, multiple blood transfusions, a prolonged mechanical ventilation time, and residual neuromuscular block. As you go on to the pathophysiology, it has been explained that the abnormalities of cholinergic neurotransmission, along with impaired cerebral oxidative mechanisms, are responsible for hypoactive delirium. Also, the CNS effects of inflammatory cytokines like interleukin-1, interleukin-6, interleukin-8, and TNF-alpha also been implicated in hypoactive delirium. And how do we go with the diagnosis? So we should have to consider the possibility of having delirium in an elderly patient who is hypoactive. And we often need multiple assessments over a period of time. And we should clarify the premorbid status and sequence of events which have occurred. We have to exclude important differential diagnoses like depression, fatigue, or major cognitive impairment. And we should try to identify all predisposing and precipitating factors. A detailed mental status examination along with a detailed cognitive evaluation including attention and concentration, orientation and memory along with a chart review is essential, and we should ascertain what are the changes occurred and when did these changes occur. A Folstein's mini mental status examination is useful as a change from the baseline. It usually separates normal from the abnormal. It's not designed for delirium. And a more useful tool will be assessing the patient in a two-step. In the first step, you should assess the patient with a Richmond agitation sedation scale where the score of -1, -2 and -3 indicate hypoactivity, along with a confusion assessment method where an acute onset of mental status changes with a fluctuating course along with inattention and disorganized thinking or altered level of consciousness. If this tool is positive, we can confirm the diagnosis of hypoactive delirium in around 90% of cases. An EEG will show a diffuse slowing, and it is useful to get a baseline, and some studies say that this diffuse EEG slowing is more prominent in hypoactive delirium. Now, how do we go with the management of a person with hypoactive delirium? So, we should have a detailed assessment of the patient, assess the hydration status, look for new localizing neurological signs, a rectal examination to rule out any fecal impaction, look for distended bladder or infected ulcers. Review the medication list which the patient is receiving now. Measurement of serum concentrations of medications may be needed in some cases. A detailed metabolic workup including complete blood count, electrolytes, urea, creatinine, glucose, calcium, albumin, liver function tests are mandatory. We should look for oxygen saturation or arterial blood gas analysis may be needed in some cases. We should do an ECG to rule out a silent myocardial infarction, a chest X-ray to rule out pneumonia, and brain imaging is done if needed. And a urine examination with culture and sensitivity is very important, and it is common in the elderly. Once you diagnose a specific reversible cause for delirium, we should treat it appropriately along with consultation with the concerned specialist. We can give you antibiotics, oxygen, lactulose, bladder catheterization or disinfection depending upon the need. But the major part of the management of hypoactive delirium is by the non-pharmacological interventions, which include providing visual and hearing aids, having a simple, clear and concise communication, reorientation of the patient repetitively. You should have familiar objects in the room of the patient, probably it would have been brought from their homes, provide a clock and calendar, attempt consistency in the nursing staff, and allow television during day with daily news. We have to also look for the timely removal of catheters or restraints. A scheduled pain management protocol is essential. We have to look for the early mobilization activities and range of motion exercises. Maintain a good sleep hygiene and maximize uninterrupted sleep. And you should control excess noise at night. You should also provide emotional support to the patient and relatives. A presence of family or staff may be calming. Regular behavioral monitoring at least once in 12 hours is needed, and we should have empathy towards the patient as well as the family. And explain each intervention before we are doing it. And maintain a systolic blood pressure greater than 90 millimeters of mercury and maintain oxygen saturation greater than 90%. You should also psychoeducate the family, the bedside nurse and other healthcare providers regarding the current status of the individual, and counseling is needed for the family and to the patient once the delirium is resolved. And you should also look for the bodily functions. We should maintain the fluid balance and hydration. We should ensure adequate nutrition, encourage self-care, and walk with assistance or range of motion at least 3 times a day. So now coming to the pharmacological interventions, till date no randomized controlled trials are being there describing the efficacy of any particular pharmacological agent in the management of hypoactive delirium. But typical antipsychotic haloperidol in a low dose around 0.5 to 2 milligram, which is given orally or intravenously or intramuscularly in 2 to 12 hours, has efficacious in improving symptoms of hypoactive delirium. The typical antipsychotics, olanzapine, risperidone, quetiapine and aripiprazole are also being used and found to be effective in hypoactive delirium. And the atypical antipsychotics are now preferred because of their fewer side effects. And the new emerging drugs which are being tried in hypoactive delirium include methylphenidate, dexmedetomidine, which is a novel alpha-2 receptor agonist, caffeine, melatonin, modafinil, cholinesterase inhibitors and ondansetron. And all these drugs are under various clinical trials, and these drugs are used in certain clinical settings and found to improve hypoactivity in hypoactive delirium. Now, what are the future directions? Further research is needed to determine efficacious and safe pharmacological interventions in managing hypoactive delirium. A comprehensive, multifaceted approach will result in a better care of patients with hypoactive delirium. And in the delirium protocol, when the RAS score is -1 to -3, it usually demonstrates hypoactive delirium, and non-pharmacological interventions are said to be the cornerstone of treatment. To summarize, hypoactive delirium is a neuropsychiatric emergency. It's common but under-recognized. The treatment to address the underlying cause, non-pharmacological approaches are essential, and pharmacological treatments are largely symptom-based. These are few of my references. Comments or queries are well appreciated, and I am greatly indebted to Dr. Shahul Amin for his help throughout my preparation, and I am grateful to Dr. V. Sadish, Dr. KP Jayaprakasan, Dr. Bobby and other office bearers of IPS Kerala State Branch for their encouragement, and I thank my teachers, seniors and my family for their care and support throughout my career. And thank you all for your patient listening. Thank you.